I know I've sent you the links to these. I don't know how you want to deal with keeping these archived or something like that for these presentations. Some of it obviously like is good teaching material and case discussion material. I don't know how much because we're using patient names and information that I don't want to like share anything that would be like, if you put it on YouTube, do you have to have like is it password protected at all or anything like that?
I can put it on YouTube, but have it be unlisted. So if you don't have the link, you can't get to it. So that's probably the easiest way. Although you remind me that I tried to download the link you sent me last time and it wouldn't let me because I'm not OSU.
Oh, so maybe I have to download it somehow.
Yeah, if you want to put them like on a Dropbox folder and then I'll just pull them out and upload them, then we should be great. Because I think they're fantastic sessions. We should certainly post them.
Okay. Are you in like a white void? You're in a very white room.
My camera is really foggy because my computer is so old, but I'm just in my house with all the lights off. So
okay, I see Jessica's here too. So I know it's a smaller group. I know that people are traveling for various meetings. Actually, a lot of meetings are going in Austin. So I think some pathologists are now in Austin for SDP, and then ACVIM is basically the following weekend. So I figured since it's a small group and case discussions might be limited since there would be fewer people, but we already have the cases lined up. Hopefully Shrop can get off of whatever things she had to do next month. And then because she and JD have two cases that have some similarities, different histories and backgrounds, but the pathology is similar and it's somewhat unusual. So I think it'd be good to discuss those in July. And then we'll go back to asking for more requests coming in August. So, and I can see a few names here. Oh, that's not gonna let me do that. Let's see. That I don't necessarily recognize, which I'm happy that the links are being shared. So I'm gonna do a quick poll to see who is here as a first timer versus who is an old pro. And I think I can now share the poll. Let's see. What happened to my Zoom? Got it, maybe not. Save. Got it. Now I want to actually post it, but it's not letting me see what I wanted to do for that. There it is. Never mind. Okay, so if you are fairly new, it'd be great to know that this is your first time. And then today, like I said, it'll be fairly basic because we will just kind of go through some it's actually kind of an old lecture I gave to anybody can, if you guys can respond to this poll, hopefully you guys can see it. First time versus yes or no. So this is actually a lecture, portions of a lecture that I gave to, I think, Antec last fall. So I just figured it's a good way for us to discuss about taking biopsies and how a pathologist evaluates them. And then I know that, sorry, I'm having really bad allergies. I apologize. I know that Dr. Hokamp is here as well, so she can talk about the biomarker urinary portions of our biopsy service as well. So, okay, so it looks like we've We've got about a little bit under half are first timers, so that's good. I'm assuming a lot of you guys are probably brand new pathology residents, so this will be good for you. Well, let me share whatever screen I want to share, which screen is it? That one? That one. Let's see. Then I need to move this down so I can figure out where my lecture is. I don't know where my lecture is. Hold on. I do understand. I know what I'm doing. I'm just not being very efficient is what I'm doing. How many things do I have open? They're there. There it is. Got it. Okay. Hopefully you guys are now seeing probably the end of my lecture. Yes, that's right. Okay. Okay, so it looks like about a little bit under half are first timers, so that's good. Welcome. Ooh. Go away. Okay, so now I just need to get back to the back. Let's go. I'm going to stop sharing and get this back to the part that I want it to be. So when you are interested in kidneys for a particular patient, most of the time what we're getting is people that are interested in performing kidney biopsies because there is proteinuria in a patient. And so that's usually our most common indication for people to perform biopsies. But we get some things for acute kidney injury, wondering to know what the prognosis might be if there is an AKI event. And so we kind of get both of those kind of overlapping things. And then the other common reason that people will perform biopsies is if they're worried about some things in the breed. So whether it's a young dog that they're considering breeding, or it's a pure breed that they just purchased and now has renal disease and they're wondering, did it come with renal disease? They'll perform biopsies to see if there is evidence of a juvenile nephropathy. So speaking of that, we do have a lot of breeds that we are interested in. So if you are a clinician or even a pathologist who is maybe doing an autopsy on an animal that has one of these breeds that has renal disease, please contact us. Our breed study for boxers is pretty much wrapped up, but we are always interested in boxers because they seem to have a high proportion of renal disease. We have an ongoing, well-funded greyhound study and too few greyhounds to enroll in it. So we really need some greyhounds. This is a Bracco Italiano. They often have amyloid in their kidneys. We always see really weird things in Yorkies, and there's a high proportion of Yorkies in our database. And then this is a Quickerhund, I think that's how you say it. And they might have a familial nephropathy as well. Please send us greyhounds, Dr. Hokiam says. Okay, so I'm going to flip through a lot of the word slides because it's really not that, it's not as important as the pictures I'm going to show you. But we have been established as the International Veterinary Renal Pathology Service. Dr. Lee's created in 2005. And then we had moved it from Texas A&M to Ohio State. We have actually now two contract pathologists. I guess technically three because I'm a contract pathologist as well. And so even though I'm no longer on faculty at Ohio State, I work through Jessica Hokamp to read the kidney biopsies. So if you're talking about kidney disease in dogs, out of our specimens, and this is probably quite old since now we probably have another 400 cases to add into this. But oftentimes, whenever we've looked at our database, about half of our dog biopsies, and usually these dogs are being biopsied because they're proteinuric. It's not just the general population of dogs, but because they are proteinuric, they send biopsies, and about half of those are immune complex disease. It's a little bit less than half. Usually, whenever we do the math again, it's usually like around 48%, so a little bit less than half. We can find evidence of immune deposits. And then amyloid is actually pretty small. It's usually less than 20%. of our cases. And now that might be that people don't biopsy animals they don't biopsy a lot of Shar-Pays. If they see a proteinuric Shar-Pei, they just assume it's amyloid. So again, there's a lot of bias in when a clinician decides to do the biopsy. But our other big category, in addition to immune complex disease, is this green category over here, which is podocyte-driven disease, so focal segmental glomerulosclerosis. It is a pretty large chunk. It's almost around a quarter of our cases. And then the gray one up here is renal maldevelopment, which is our technical renal dysplasia, however you want to say juvenile nephropathy. Those are those animals up in that gray category. Cats are a little bit different. When we get biopsies now, we have many fewer cats. If you look back, we have about, at this point in time, we had about 1,500 dogs and we only had about 150 cats. So much fewer cases, but their most common indication or biopsy diagnosis has something to do with, you can't really see that, but that says acute kidney injury. There's a little thing that's over it, sorry, but acute kidney injury, tubular necrosis. They'll often have a lot of inflammation, but it's more of a tubulo-interstitial process as opposed to a glomerular process. Okay, so we recommend biopsies, especially if the clinician is trying to decide about a treatment protocol. And so we as clinicians kind of categorize 3 different types of proteinuria. And so this isn't really that commonly discussed. Nephritic syndrome isn't really that commonly discussed in veterinary medicine, but it's a common term we use in human medicine. So nephritic patients will be proteinuric, and they'll have some degree of azotemia. And then when they look at the urinalysis, they'll have an active urine sediment. Now, whether that means red blood cell casts, leukocyte casts, obviously you have to rule out the possibility that they have an underlying UTI. So as long as that's ruled out and there's culture negative, they might have granular casts from tubular necrosis, or some type of active urine sediment. And again, they'll be mildly to severely azotemic, just depending on how bad that is. Nephrotic syndrome will be the 4 characteristics that you guys learned in vet school. So proteinuria, hypoalbuminemia, dyslipidemia, usually a hypercholesterolemia, and some type of third spacing, whether it's ascites or that. So that's nephrotic syndrome. Now, oftentimes we can have patients that have pretty marked proteinuria, but do not have all the categories or all the conditions for nephrotic syndrome. So maybe they're not having ascites or anything like that, or maybe their lipids are within normal limits. And in those scenarios, we'll call that nephrotic range because it's a bad proteinuria, but they're not actually having the whole criteria for nephrotic syndrome. And usually we consider that to be around a UPC of greater than 3. And that's just kind of I don't know, like an anecdotal cutoff. I mean, some people would argue maybe we should say 2.5. I'm not sure, but we usually say as long as it's high, but they don't have all the categories or all the conditions of nephrotic syndrome, we'll call it nephrotic range. And then, as I said before, we worry about it when we see renal disease in puppies. Usually in young animals, the most common clinical symptom or the most common indication that they might have renal disease is their inability to concentrate. So they probably will not be proteinuric, they won't be azotemic, but they'll have a low urine specific gravity and it would be repetitive. So that's usually the first clinical indication. And then that's when the owner says, okay, well, maybe we're going to go ahead and spay the animal anyway. So let's go ahead and grab kidney because we're not sure why this dog can't concentrate its urine. That is probably, well, I would say I've never seen it published, but that's just what we've noticed as far as renal disease in puppies being mostly isoscenuric. And I don't think we've ever published that. Okay, so we have lots of different types of diseases and we have lots of different recommendations for how you treat the diseases. Trying to get to pictures. We suggest to clinicians that they take a biopsy, especially if the patient is an AKI event or nephritic, that once the patient's stable, that they can go ahead and take the biopsy at that point in time. Hopefully the patient is no longer or is not hypertensive. Hypertension is, especially severe hypertension, is a contraindication for renal biopsy in our experience. That being said, we have biopsies from a lot of very hypertensive patients and it's been fine. But the outcomes that have been poor, those patients have been hypertensive. When I say the outcomes that have been poor, what I mean is when they've had a biopsy and the patient has either had significant hemorrhage or we've had 2 patients that have died post biopsy, a couple of days after biopsy, and both of them were severely hypertensive. Now, if it's a patient that is just nephrotic or nephrotic range, usually those clinicians will wait longer before they decide to biopsy. And that's fine. It's really about when it's a good opportunity for them to decide to sedate the patient, to anesthetize the patient. It's more about, you know, how quickly or how slowly it progresses. So we have some patients that have been years of proteinuria and then they finally decided to biopsy. Now that could be a risk because maybe that patient's going to develop a lot of scar tissue during that waiting period, but it's not as urgent as an AKI event. And then oftentimes we get biopsies from young animals, especially puppies, when they're going to be anesthetized for a spay or neuter. We don't see, I would say, in my experience, it's extremely rare to get biopsies from cats where renal dysplasia is suspected. I really don't think cats have maldeveloped kidneys. I think I probably have only been suspicious about it once or twice in general, but puppies often like to have maldeveloped kidneys. Obviously, we don't want to biopsy a patient that's going to have hemorrhage, especially if there's hypertension. We want to make sure that there's no anticoagulant therapy being given at the time of biopsy. And then oftentimes we don't really recommend biopsying cystic diseases. You can see a cyst on an ultrasound. There's no really reason to biopsy it. Okay, so we get mostly ultrasound guided core biopsies at our service. Some clinicians still like to do a lot of surgical wedges, especially if that's more of their experience and they don't have a lot of experience with true cuts. We do like when we get wedges for suspected renal dysplasia maldevelopment because that gives me a lot of tissue to look at. It's much more tissue than a core biopsy, so it can be very helpful to have a wedge in that situation. Sometimes we'll get biopsies where maybe they're going in for a splenectomy or something like that, and they decide, well, this patient's been proteinuric for about 6 months, let's go and take some kidney. And so they're already intra-op. And this still happens to this day. We've had, I think a month ago, we had this situation happen where we warn the clinician, don't push the needle in too deep because you're just going to harvest medulla, and it will actually happen that way. So not a good idea for that scenario. We do get a few nephrectomies, especially if there's a renal mass. Laparoscopic procedures have been successful if the person's really good at laparoscopic procedures. So it would be something where if you haven't done many of them for other things like liver or anything like that, like I wouldn't recommend starting with kidney. We get there have been quite a few laparoscopic biopsies where we just got renal capsule or maybe just the smallest amount of cortex, because when they did the little grab, they weren't really going deeper into the kidney.
Or sometimes spleen.
Oh yeah, we get spleen. We've gotten GI tract every so often. We'll get liver. There was one time I got when I was at UNC at the Human Hospital where I got like a full thickness of jejunum. And I was like, is this bad? Like you put a needle and you put a thing in the whole jejunum.
That's where the surgeons need to make the call to the client. I'm sorry, I missed. I poked the wrong kidney because it's instead. I want to get to the pictures. Okay, so this is actually not from our publication. This is from a human paper, but it's just to show any of the clinicians that are on here that you really should be able to see the little nubbins in here that are going to be the glomeruli. So in this particular core, we have at least 4, probably 5 glomeruli here. And then if you compare that to a core that's mostly medulla, which has very small pinpoint vasculature, the vasa recta live in the medulla. So it's like an arborized network. And that's why you would see a lot of vasculature around here in the medulla, but you should see discrete glomeruli in the cortex. This is a picture from Dr. Lee's, and he kind of does a backlighting of this renal core. So again, you can really see the glomeruli hanging out in here, and then you can see the tubular profiles kind of going around the glomerular tufts.
So if you're the one taking the biopsy or you're next to the patient and the ultrasonographer is taking the biopsy, it really does behoove you to look at that sample and try to make sure you're giving me glomeruli, because it's kind of a waste, and it takes time, right? To send me the biopsy and I have to look at it. I can't find glomeruli, then we process more, still can't find glomeruli. And so in the end, the owner doesn't really get a diagnosis. And that's comparison to this other picture that Dr. Lees took, which is medullary tubules. So they're all running parallel to one another. Okay, so for the pathologists that are here, you guys probably know that the special thing about the kidney biopsy service is we do a lot of electron microscopy. We do transmission electron microscopy. In human medicine, they do a little bit of scanning electron microscopy, but it's not really well commonly used. So we use transmission electron microscopy, and there is a special fixative for TEM. And so it is useful to take a small core and put it into the glutaraldehyde. What happens now is that the clinician sends me everything in formalin, and then the technician will change it from the formalin vial into a glutaraldehyde vial. So we don't have to send a whole bunch of glutaraldehyde vials out to different various veterinary practices. It's just one less step that the veterinarian has to do. So we transfer it over to formalin. That being said, now let's say you are a pathologist and you're doing an autopsy on something and you had no clue, or it has renal disease, but you didn't realize it was going to be really cool glomerular disease, and you're interested in working it up further. We can do electron microscopy on formalin fixed tissue. It is completely doable. We tend to like it on samples that haven't been fixed for a very long time, because if it's fixed for over 4 to 5 months in formalin, there can be some artifact, but it still can give you a diagnosis. It's still good enough as a sample. It's just maybe not publication quality. And let's say you guys give us something in glutaraldehyde and it didn't have any glomeruli in the sample we took over to the EM lab. So the EM lab looks at it, they can't find glomeruli in that core. What we do is we take them the block, the paraffin block, and they melt the block, and then they can process the tissue that's hanging out in that paraffin block for EM. There's always a rescue mission that can happen on EM. They can melt the IF block as well, the frozen OCT block, and do EM on that. So think about it. These are people who do this every day for human kidney biopsies. So they have a lot of different ways and methods to rescue a sample in the event that glomeruli weren't originally harvested. So we only need like one, well, I would say there are many cases where I only look at a single glomerulus on EM. I don't need 10 glomeruli. I don't need a lot of samples. I just need 1 or 2 in order for me to verify a diagnosis of immune complex disease or to rule it out. So it really can be very useful to have these rescue methods. When I do immunofluorescence, we actually recommend, we do send out these little small vials of a transport media. It's a buffer. And so you put, the clinician will put a core into formalin and a core into the Michelle's, and that Michelle's doesn't fix the immune complexes, and that's why we use it. It just basically keeps it at the regular pH and with the right electrolytes. And so then when it comes to our lab, we do a lot of washes, and then we embed it in OCT. And so let's say there's times where maybe the Michelle's is expired or the clinic didn't have a kit. Then we recommend that they can just put it in saline and hopefully get it to us ASAP. And then we can do the same thing when it arrives in our lab. So Michelle's should basically keep the tissue freshish for 5 days, according to the product label. The saline, we really need it within 24 hours, because we'll start to see some artifactual change if it's not in the Michelle's. So those are kind of like the various things that all happen with a kidney sample.
Hey, Rachel, quick question. Since we no longer have the separate glute vial for most samples, but the sample for EM needs to be fixed more quickly than the sample for formalin, do you encourage clinicians to write down which core, like the size?
There's the stuff that we're doing is, so like when we and Fred used to say that, Fred Fleb used to be like, oh, it has to be in there and it has to be chilled and all that stuff like that. you're gonna from a diagnostic standpoint, it doesn't really matter if it sat out for 3 minutes or 10 minutes or whatever. I can still see deposits when I need to. So yeah, it's not that big of a deal. But the person that we used to work with, Mary's talking about, was very he did a lot of stuff where he did a lot of device work. So he would look at like heart tissue with like electrodes in them and stuff like that. So I'm assuming for that, yeah, you had very specific measurements that you were going to have to do. And it probably was a big deal to have it in formalin as quickly as possible. But from a diagnostic standpoint, like when we were at the kidney summit in Boston, Fogo doesn't even use glutaraldehyde. She puts them right from formalin. She never puts the sample into glutaraldehyde these days. So I think from a diagnostic standpoint, it's fine.
And within 30 minutes would be totally fine then?
Yeah, I mean, I've seen cases where the animal has been euthanized and then they took samples, later that day, and we've still seen, we're able to see. Now, it's not great, but I can tell you, oh yeah, there's immune complex disease here. So yeah, I don't have a problem with that. Does that make sense?
Clarifying. Yeah, no, I just didn't know if you tried to figure out which one might be the fastest fixed based on the clinician's notes or anything.
No, we're just trying, like Dwayne does his best to see which one looks like the best quality. And then and if they do a small piece, he'll put that one in the glutaraldehyde just because it's a small piece already. But like we have a pending case that didn't have any glom, so we're having to embed the other pieces as well. So it's it can be frustrating sometimes if there's a lot of time that's been spent and people have done the ultrasound and stuff like that and still not gotten glomeruli, but it happens. Okay, pictures finally. Okay, you guys, for those of you guys who've seen me lecture before, you probably have seen this picture, but I just like to use it to emphasize that the PAS is one of those stains that's very helpful for figuring out where cells are located and how many nuclei there are. So I find the H&E over here on the left to be a little bit blurry to see where these nuclei are located. Are they in capillary lumens? Are they in the mesangium? Are they on the outside of the capillary lumens? But when you do a PAS, you can clearly see here's a capillary and here is your endothelial cell. Hopefully you guys are seeing the arrow that I'm drawing, hopefully. And then you can see that there are at the base of this port, kind of near 6 p.m., 6 o'clock, I guess is the right word. It doesn't have to be p.m. There are nuclei, and you can see that pale pink cytoplasm of the podocytes. So you know that these are podocytes, and then here is our capillary wall. So it's a very easy stain for the delineation of where the glomerular base membrane is, where the podocyte cytoplasm starts, where the mesangium is in the center, kind of that tree trunk. And then knowing that it's at 3 micron, we have a limit of how many nuclei are allowed to be in certain locations. So in a capillary lumen, you're allowed to have one single nucleus. So like, let's go back to this capillary over here around 9. You have a single nucleus at the base, and that's the endothelial cell nucleus. So everything's great. But if you go to the mesangium, which has a lot more pink around it, that fuchsia of the PAS, we can see that there are 3 nuclei here, and that's our max that we're allowed to have in the mesangium. So 2 to 3 nuclei in the mesangium. But if you go out here, we can find like 6 nuclei. So we know we have too many nuclei in this one particular segment. And for me, I couldn't tell you where things are located in the H&E. The trichrome can be very helpful if you find deposits. They don't look usually this beautiful. This is just an amazing case where they were gorgeous. I'm evaluating a case right now for Florida. I'm not sure if Autumn's on this call or not, but I was able to at least see a few deposits on that case. And so I could tell her immediately, well, not immediately because it took me a couple days to get the slides, but I could tell her even before we did electron microscopy, like this is going to be an immune complex disease because I can already see the deposits even with just regular light microscopy. Now, if the deposits are really small, you're not going to be able to see them. They're not going to pop out like this. If they're very, very small early deposits, this is going to be something where they've been going on for a bit and they're quite large. And a normal glomerular wall should be just a blue line on a trichrome, and you should have a single nucleus at the base, which is where your endothelial cell nucleus. The Jones is very good for remodeling the glomerular based membrane. It's still one of the hardest stains. I guess maybe I shouldn't say hardest. It's a finicky stain. So many labs can't do this. We started doing it at Zoetis, and we are using our auto stainer program, and it seems to be working pretty well. But OSU still does their Jones by hand. But if you can see what a normal capillary wall should look like, which is very smooth, just a very smooth outline of that capillary, that black stuff is glomerular based membrane. And then this black stuff over here is the material that's making the mesangium. So they're very similar components. And so that's what a normal capillary loop and mesangium should look like. Whereas in this particular patient that has immune complex disease, you can see all these tiny little prickly spikes that are little projections of glomerular based membrane, and they're going outwards to the urinary space. And then sometimes these deposits are actually being encircled by new basement membrane material. So this is chronic. We know it takes time for this to happen. And actually it's the same dog as this one. It's the exact same glomerulus. So all of these little red dots over here are causing or telling, or I wouldn't say telling because it's not, I'm trying not to personify, but the deposits are activating the podocytes, and the podocytes are upset by having to touch the deposit. So they start to make their own new basement membrane, and they make these little projections in between the deposits, and then the deposits are eventually encircled by new basement membrane material. So we can say there's immune complex disease and it's pretty chronic. Another way that a glomerular based membrane could remodel is if the deposits are by the endothelial cells. And I guess I should remind you guys that the endothelial cell and the podocyte are both synthesizing GBM material. They're together making the GBM the full thickness, and they're turning it over. It's not a static structure. So they're always kind of adding a little bit to it and making sure it's still stable within that capillary loop. And in this particular dog, we had deposits, but they were beneath the endothelial cell. And so the endothelial cell started synthesizing new basement membrane. It's weird because when podocytes make their basement membrane, there's a lot of spikes that happen towards the epithelial urinary space aspect. Whereas when endothelial cells make their new basement membrane, they just basically make a flat line. So like a complete new line of material. And so here's a capillary loop. We even can see one nucleus that's basically so activated. It came from the mesangium, and now it's trying to grow into this glomerular capillary wall. And so this would be what we call double contours. And that would be something that's more common with subendothelial deposits, whereas these spikes and holes are more common with subepithelial deposits, so beneath the podocyte. I will do a Congo red if I'm worried about amyloid, or if the breed is right for amyloid. A lot of dogs have really weird, not a lot of dogs, some dogs have a lot of lipid in their glomerular tufts, and so you can do an oil red O on those to prove that it's lipid. Cats have a lot more hypertensive nephropathies than I think is actually, it's not as well recognized as it should be. So in order to prove that there is vascular disease in cat kidneys, I often will do an elastin as well. Okay, so when I'm looking at a biopsy on histology, I'm trying to figure out how many cells there are. If there are too many cells, then I have to tell the clinician, is it mesangial? Are there a lot of cells in the capillary lumens, or is it a mix of both of those? Podocytes should not proliferate. So in almost all animal cases, we will not have hypercellularity of the podocyte component. It's very, very uncommon to see podocyte proliferation. It does happen in humans, and there are a few animal models, experimental models of it, but it's not something that commonly happens in dogs or cats. I would say less than 1% of our cases in our database have evidence of podocyte proliferation. Mesangial cells love to proliferate. So if I see hypercellularity, it could just be like mesangial cells just deciding to, I don't know, reproduce. They will reproduce for a lot of different reasons. They might reproduce because why am I saying reproduce? They might proliferate because there are immune deposits. It's very possible. Maybe there's immune deposits in the mesangium, and so they will proliferate in that scenario. But they also could proliferate because there's amyloid in there, or because the capillary wall was unstable, and so they needed to make more so that they could strengthen that capillary wall. So mesangial proliferation is very nonspecific. It happens in a lot of scenarios. Endocapillary proliferation means that there are too many nuclei within a capillary lumen. Now, that could be endothelial cell proliferation. It could be that the endothelial cells didn't increase in number, but they got really large. So because they became so much larger, you could see a few of them in one single cross section, because now they're all crowded because they're big. Endocapillary proliferation could also be, now it says proliferation, but what the technical word should be hypercellularity. It's just not the common parlance, whatever, however you say that word. It's not the common jargon. But you can see increased numbers of cells inside capillary lumens when there is inflammation and you have attraction of leukocytes to the capillary lumens. So if you had immune deposits in there and you're activating complement, you are sending off the little complement fragments, so C3A and C5A, and those are attracting leukocytes to that particular capillary lumen, and those leukocytes are basically going to hang out inside that capillary lumen. So then when I see a histology slide, I will have a lot of nuclei within a single capillary lumen. And it's annoying because it's called proliferation, but in actuality, in that last scenario, it's recruitment, right? It's not, they're not proliferating, they're just recruiting. But the term that we use is proliferation. And a lot of times you'll see both of these together, mesangial and endocapillary hypercellularity. Mesangial expansion is fairly nonspecific as well. You can just increase mesangial matrix for many, many different reasons. I also will comment in my report whether or not there is loss of the capillary lumens. For example, if you had sclerosis, you're going to lose that lumen of that capillary. If I'm lucky enough to see an immune deposit already on the trichrome, I will comment on that. And then based on the Jones, if I can see evidence of remodeling, I will comment on that as well. If I'm looking at EM, like I said, you don't need to evaluate that many glomeruli. It's incredibly uncommon for me to evaluate more than 3 glomeruli on an EM, but I'm going to look at the podocyte itself. I'm going to see, are the foot processes effaced? Are they fused together? Have the podocytes detached? Are they hanging out in the urinary space? I'm going to comment on the glomerular based membrane. If there are electron dense deposits, obviously I'm going to mention that. I'm going to tell the clinician where those dense deposits are located. I will assess the endothelium. I will say the endothelial cells can kind of swell just non-specifically, so it's not always a specific lesion if I see endothelial cell injury. And then looking at the mesangium, are there too many cells there? Are there fibrils there? Are there deposits in the mesangium? And then we get to see lipid in a lot of dog glomeruli, not necessarily cat glomeruli. Okay, so and then the IF, the last part that is part of my report, is looking for a granularity, and so looking for specific. I think the next picture shows it better. Let's see. Yeah. So all of these little dit dots are discrete immune deposits. Lambda light chain is our most robust immunofluorescence stain. So every single blob right there is lighting up an immune complex deposit. So when I'm scoring my IF, I'm looking at which immunoreactants are positive. So it's usually a light chain and a heavy chain. In dogs, we can also look for complement associated complement association with these immune deposits. We don't have a good immunofluorescence for cats, but for cat, I should say, we don't have a good immunofluorescence for cat C3, but we do have it for the immunoglobulins, heavy chains and the light chains. And so telling the clinician what part of the glomerulus is being labeled. So here you can see this would be a capillary loop. So I can tell them that capillaries are being labeled and mesangium is being labeled as well. And then it's a discretely granular positive labeling. There are a lot of other things we look at in human IF. So if I'm looking at an IF sample from a human patient, I could be worried about a linear pattern as opposed to a granular pattern. I could look at different aminoreactants. We look at other complement products and stuff like that. We don't have that capability in veterinary medicine, so it's much more limited to see what I can report on for immunofluorescence. Okay. Okay. So the other thing, which is what I wanted Dr. Hokamp to be able to comment on, would be submission of urine and plasma. So we call those biofluids. And when they come to our lab, we process them, and I'm going to let Dr. Hokamp talk a little bit about that, and then how we try to correlate that back with the disease manifestation. And you don't have to show anything, Hokamp, unless you want to show a gel.
When I saw that you were doing a presentation, I really quickly pulled a presentation I had and like dumped out some other stuff. And I was like, okay, I'll be ready to present this.
Well, I think you can share your screen if you want to do that. So I just feel like I just wanted you guys to get an idea of like, if you guys attend these rounds in the future, these are the components that you're going to be hearing us talk about. And we're going to talk about GBM remodeling, deposits, what the urine showed, and all of that stuff. So that then that way, you know, next month when we talk about this really cool thing that's really uncommon, you'll be able to already know, okay, well, what did the IF show? So now you already know what we look at when we're looking at IF. You already know that we're interested in the glomerular base membrane when we're looking at EM. So do you want to share your screen?
Sure. So as Dr. Cianciolo mentioned, as Rachel mentioned, I guess I should say, hold please.
Why are you wearing a sweater? It's so hot outside.
But it's not inside. Wait. Hang on. You think by now I would know how to use Zoom.
Yeah.
Go to that monitor. Go over there. That's that. Share screen. Share screen too. Okay. So I'm gonna have this up while I'm talking for a second. As Rachel said, we accept biofluid samples. The most common biofluid that we receive is urine, but people also send serum and plasma. The predominant aim of having the serum and plasma available to us is not that we currently have a novel test developed for that, but we're working on things. But it's so that we have the material available to use to correlate with the renal biopsies that we are being sent in order to develop novel minimally invasive tests. And that's actually how we developed the SDS-PAGE test that is now available to clinicians. So SDS-PAGE, that stands for sodium dodecyl sulfate polyacrylamide gel electrophoresis, but basically it's taking urine and separating out into its different protein molecular weights based on the major protein components in the urine, so that we can get an idea of the origin of the protein, where it came from in terms of predominantly glomerulus, predominantly the tubular component, or both. And we found that we published in 2018 demonstrating that the severity of the banding pattern on the SDS-PAGE gel correlates actually relatively well with the severity of glomerular damage and moderately well with the severity of tubular damage on renal biopsy. So for those individuals who can't necessarily perform a renal biopsy, but say, for example, have a mildly proteinuric patient where they're not entirely sure if the protein is originating from the glomerulus or the tubules and are trying to decide whether or not they should do a biopsy or if they should start on anti-proteinuric therapy based on an assumption that it's glomerular disease. we can do an SDS-PAGE to get at least an idea that yes, this is predominantly glomerular, yes, this is predominantly tubular. So this is the main test that we do as a novel biomarker test. We are working on other things, and it's hopeful that in the future we'll have additional tests available through our service. But again, we always want to base that on the correlations of the renal biopsy findings. So this gel right here, if you ever get a report from us, you'll get an image that looks similar to this, except without all the red little whatever you call these things, brackets. On lanes 1 and lanes 10, this is something called our standard markers. So this tells us how heavy the molecular weight proteins are. And then each one of these lanes from lane 2 to lane 9 are different urine samples from a patient. And we process these appropriately and basically spread these out on a gel. And if they have predominantly proteins in the intermediate molecular weight region up to the high molecular weight region, those are consistent with a primary glomerular damage. If they have if they have proteins in the intermediate to low molecular weight region, those are consistent with a predominant tubular damage. And if they have a mixture of both, then we consider that there's probably a mixed component of both glomerular and tubular damage.
Jessica, what was lane 2? Was that just like nothing?
That's a normal patient. Yeah. So this is what you would see if you had, it is actually normal to have just a teeny tiny bit of albumin and what's probably TAM horsefall protein. It's a normal protein component. So this would be a normal patient. So, you know, why would you want to do this again? If you had a patient where maybe the owner is not ready to do biopsy and you have UPC that maybe is less than 2 and you're not quite sure if this is glomerular damage yet, maybe this is predominantly tubular damage and you're trying to decide if renal biopsy would be helpful, this would be something that you could go forward with just collection of urine. We request that urine is submitted to us as a whole urine specimen so that we can perform urinalysis on it to see if there are a lot of cells in it, because if there are a lot of white blood cells or a lot of red blood cells, that can actually throw off the banding pattern, because anything that's there that would contribute to proteins can affect the overall banding pattern. We request that if you send urine, we're always going to try to get those urine samples as fast as possible. Urine is a volatile sample. And so if you collect it and let it sit in the fridge for several days or sit on the counter for a while, not only are we going to have breakdown of the sample and of the proteins that are there, but it can also start to grow bacteria or grow even mold sometimes, and that will absolutely contribute to the banding pattern on the gel. And we don't want to overcall a particular banding pattern based on a contaminant. So our request is that if you collect it, you send it out same day as much as possible, and send it overnight to us so that we receive it within 24 hours, and it needs to be sent on enough ice packs to stay cool. If you collect it on a weekend or on a Friday, we can give you workarounds for how to prepare for that. My recommendation in those cases is to spin down the urine, so actually remove the supernatant from the sediment and freeze the sediment, and then ship that to us during a weekday. And while yes, there is risk that, you know, there might end up being a freeze thaw sample unless you can send the sample to us on dry ice so that it comes to us frozen. That's probably better than if there is mold or bacteria that grows in the sample. But ideally, it's best to collect the samples Monday through Thursday and send it to us before a weekend or before a holiday. So some other things that we are working on with this and other information that I will try as much as possible to give you if you perform SDS-PAGE is Okay, so this is from that paper that I mentioned that we published in 2018, where we demonstrated correlations between the banding pattern severity and biopsy severity. I'm going to put a plug in here for Dr. Madison McKay's poster that's going to be at ACVIM. For any of those, for those of you who might be there now, she will have this up whenever the posters go up. I don't know when, but this, what we've been noticing over the last several years is that when we get banding gels with banding patterns similar to this one in lane 9, where we have frequent bands, particularly if they're really, really prominent or right up at the top of the gel, we find that the vast majority of these cases are membranoproliferative glomerulonephritis, so one of the forms of glomerulonephritis that Dr. Sanciolo was talking about, that is very inflammatory. And this is still some initial data, but what I do when I see this pattern, I recommend to the clinician that, especially if a renal biopsy cannot be performed to confirm this finding, I recommend cautious and well-monitored use of immunosuppressive therapy. There are some patients where they have not been able to do a renal biopsy at all, and being able to have that confidence to go forward with immunosuppressive therapy has actually improved quality of life in those patients, at least from my understanding. And I think certainly any of the clinicians on this call might be able to speak to that maybe a little bit more. We've also seen this in cats as well. We certainly have less data in cats because we don't have as many renal biopsies correlated with urine, but this is something that we're currently working on. But I'm seeing this same pattern of multiple or prominent bands that are very, very heavy in the urine that seem to correlate more commonly with MPGN than other diseases. There's potentially some caveats to that, but we're continuing to work on that. So this is just basically a plug for, or maybe not a plug, but just to a little bit explain what we're trying to do with this urine SDS-PAGE, and some of the information that you might get back from me if you've ever submitted an SDS-PAGE report, or if you ever do so in the future. And I'm always happy to, if there's something that's not understandable in the report, I'm happy to explain that further. And I'm going to stop sharing because I think there's some questions.
Yeah, Astrid, you raised your hand. Did you have a question or was it an accident?
Oh, no, I have a question.
Okay.
I wondered if we use the UPC usually as detector of proteinuria, but there's, at least in our country, there's differences between laboratories, and I think it's due to technique or the things they use. But I wondered if you could give an indication on how many times, or no, what would be the risk that we miss tubular proteins, because the tests are more developed for detecting the glomerular loss of proteins, and that the tubular proteins are so small that they're just not recognized.
Yeah, that's a good question. So and I assume you're talking about on SDS-PAGE, is that right?
Well, I think usually in private practice, they do a UPC at best, and if you're really unlucky, just a dipstick.
Yeah.
So then sure we miss a lot, but yeah. I want just the UPC itself. So not the SDS-PAGE, because you see the band. So then I know what we are detecting. But in the more commercial available tests, the UPC is more often used as a name, but not as a similar technique.
Absolutely. I think it's definitely a risk to miss those if we're just doing UPC. To be fair, the vast majority of cases where I have correlation have been predominantly glomerular damage, but I do have some cases that UPC was borderline, maybe not even truly elevated, but it was one of those where a patient was just continuously borderline proteinuric or 1+ proteinuric on dipstick. And I think I do have a classic example of that somewhere in one of my presentations that did end up being an acute tubular necrosis, or at least predominant tubular injury. And you could very well see that on the banding pattern, but that wouldn't, it might be something that would raise alarms based on, I think the UPC on that one was a 0.4. So it wouldn't it's borderline, but it wouldn't necessarily say to somebody exactly what was going on in that case. That said, in those cases, we'll have, in many cases, we'll have azotemia. That's oftentimes pretty marked. But this is something that we're definitely looking into more. I just haven't had as many biopsies with those in terms of the ones that correlate with SDS-PAGE, but as you said, you're talking more about the UPC. So I don't know if anybody else has any comments about that, how often you might be missing primary tubular damage with just UPC.
There's a comment from Shropshire about a study you guys are doing with low UPCs.
Yeah, many
Yeah,
of the dogs, such
yeah, I was just gonna say that. I mean, to that point, I think for the study we're doing at CSU, it's a little bit of a weird study. It's just kind of from anecdotal stuff that people tend to say with proteinuria and in quote inflammatory diseases, or when they start animals on prednisone. So the study is looking at different groups of cohorts of dogs, one with ITP, one with IMHA, one with IMPA, and then quote non-immune aspiration pneumonia and DKA. And a lot of these dogs have a variety of proteinuria at baseline, and then we're following them at 1 week, 2 week, 4 week, and then usually plus or minus 8 to 12 week, but we're doing UAs, UPCs, and SDS-PAGEs. And so far, I think that could potentially, as a lucky coincidence, could potentially help answer that question, because a lot of the dogs, we had an aspiration pneumonia dog we enrolled yesterday that had a USG of 1048 with 2+ protein and a UPC of 0.8. And so that'll be interesting to see what the banding patterns look like. I think most people would say off the cuff that for mild proteinuria that's coming from the tubules, you should still be able to pick it up a bit, at least from previous literature, but we really don't have comparisons with banding. So maybe that'll help, because I think we'll have 20, 40, maybe 60 dogs to look at multiple time points. So maybe that'll help.
Yeah.
And kind of as their point, like even it's very uncommon for clinicians to decide to biopsy those dogs because the indication of proteinuria isn't there, and then they're usually not severely azotemic. So for a clinician, like, I'm going to do an invasive procedure. So that's why it's been hard, because even though we might have the ClinPath data, we don't have the biopsy comparison to say, oh, Rachel didn't find anything in the glomerulus. The glomeruli were definitively normal on biopsy, and everything that was wrong with the kidney was based on the tubular epithelial cells. Right. So that's where it's been difficult for us to kind of get those two pieces of data together. And we have a few cases. We'll have a few where every so often it's like, oh, surprise, it was just this. But it's not as large of a cohort as we've been able to do with our glomerular disease samples. So we are kind of coming up at 2 p.m. So I want to be respectful of everybody's time to be able to join other random Zoom meetings that they might have. We will have rounds with case discussions in July. You should get a similar email. Becca, can you send me a text or something like that to remind me to put you? I don't know how you got off of the invitation list. If any of you guys are newbies and want to be on the invite list so that you can be directly invited, please send me an email. You somehow got an invite passed down, so you can see my email is cionciolo.14. And we will have you added to the list, and hopefully the list can be maintained appropriately. And then you'll get an invite for attending next month. And this is kind of how they'll go, but they're more case discussions as opposed to lecture based. Okay. Any other questions? And then if you are a pathologist and you have cases and you really want to see if they have glomerular disease, please send us emails. We try to help you guys out as much as we can. We do try to make exceptions, especially too if there's certain scenarios where we can't afford because of cost or whatever. It's not like we we try our best to help investigate new diseases and not just only look at the same thing over and over again. So I think I just did a whole bunch, I did like 3 or 4 ferrets for Becca at CSU. So anything exciting, we're happy to do, but just make sure you give us, contact us, and we'll figure out scenarios for how that will work. Is that good? Thank you, HoCamp, for co-lecturing with me. Bye.